BRCA2. We know that pancreatic cancer risks are elevated, again, more for BRCA2 than 1. And prostate cancer, again, more for BRCA2 than for BRCA1. And this prostate cancer is the type that men generally die of, not die with. And so this has led to a more aggressive screening. By the way, I know I'm always supposed to say pathogenic variant, but most of us still fall into the trap of using the word mutation. And so I'll grant you permission for going back and forth between the two. Hi, Shayna. It's good to see you. What we do know also about individuals with BRCA1 and 2 pathogenic variants is that we have interventions that can significantly decrease risk. So with breast cancer, preventative mastectomy or risk-reducing surgery significantly decreases risk to around 1 to 2% lifetime. And for the ovarian cancer risk, removal of the ovaries similarly decreases risk again down to about 2%. So we know that interventions can really help. And we know that risk-reducing salpingo oophorectomy is also associated with a reduction. We can also see that therapeutically, there's been major advances since 2014, which is pretty exciting. And that was when the first PARP inhibitor was approved for BRCA-associated cancers. Again, this class of drugs called PARP inhibitors inhibits a specific type of DNA repair pathway, and in the setting of a BRCA1 or 2 mutation, leads to cell death. And so these drugs have been approved for metastatic breast cancer, 2 of them, olaparib and talazoparib. They've been approved for prostate cancer, olaparib and rucaparib. This is for metastatic prostate cancer, for metastatic pancreatic cancer, and for ovarian cancer. 3 drugs have been approved, one much more not specific to BRCA1 and 2, but all of these are very effective in BRCA1 and 2 mutation carriers. And so this has been extremely exciting that these FDA approvals have occurred really in all the canonical tumors which are associated with BRCA1 and 2, and really was not something that we really thought could happen. How you target a gene that's turned off has been unclear. But these ways that we think about using genetic information kind of comes back when we start talking about these other genes and VUSs. I also want to show you some of the data. This is a study that we were fortunate enough to be part of, looking at olaparib compared to chemotherapy in patients with metastatic breast cancer. And again, this is a pill compared to chemotherapy. And you can see that there's this improvement in progression-free survival, a significant improvement in overall response rates. And so this is really was the first targeted therapy to be shown, particularly in triple-negative breast cancer, to be superior to chemotherapy in the setting. Now, what we have also seen is that the line of therapy may matter. And you know what, I'm gonna go back and launch these so I can see the animation. Sorry about that. You know, my pretty animation all got lost. Can you still see the slides when I do it like this? Okay. So this was the overall survival for the olaparib in metastatic setting, and you can see that there was no difference. But when we looked at it by line of therapy, you can see that in individuals that were taking olaparib with no prior chemotherapy, there was this significant improvement compared to those who were not. This was a specified secondary analysis and needs to be taken with caution, but it does lead to this question that administrating earlier in the setting would be better. And this is supported by data from ovarian cancer, where when given in first-line maintenance, so ovarian cancer patients with BRCA1 and 2 pathogenic variants who get their chemotherapy and then were randomly assigned to olaparib versus a placebo. So this is first-line maintenance, or what we might call adjuvant setting. And you can see this incredibly significant difference in progression-free survival, which is quite striking. We don't know if this will lead to an overall survival benefit, but I think everybody's betting that it will. And again, the idea is that the earlier you can treat, the more you may avoid acquired resistance. This study called Olympia, which again, I've been lucky to be a part of, it looks at adjuvant olaparib in breast cancer patients with germline mutations. So these are women who get all their chemotherapy. That's standard. They have local breast cancer, not metastatic, and they were randomized to olaparib versus a placebo. This was 1,800 women, so you can imagine this was a huge trial that took cooperation through, every continent. Well, I'm not sure Antarctica wasn't represented, but all the other ones were. And we just heard last week that the IDMC has concluded that olaparib actually does result in improved invasive disease-free survival versus placebo. So this is a big deal, but the data will not be available. The actual data will not be available to ASCO. So we'll see exactly what this looks like, but this is important. So we've shown how for BRCA 1 and 2, we can use this information for risk assessment, we can use it for prevention, we can use it for treatment. But what's happened, as we all know, is the rapid rise in multi-gene panel testing, where we're not just testing for BRCA 1 and 2, we're testing for all sorts of stuff. And we are increasingly detecting mutations in what we term moderate penetrance genes, so that have much less risk than BRCA 1 and 2. And we also know that this use of multi-gene panel testing has a very significant increase in the detections of variants of unknown significance, which I'll show you in a minute. But first, I want to focus a little bit on these moderate penetrance genes. And these are the genes that for years, over time, we've shown clinical validity, at least with a subset of them, meaning that pathogenic variants in these genes are truly associated with risk. But clinical utility, meaning that knowledge of this information actually is helping patients, has been a little bit more elusive. So the first question, though, that we have to ask is, what are the risks of these in the general population? Because most studies have ascertained based on young individuals with cancer or significant family history, or from genetic testing laboratories like Ambry will frequently has done a lot of great publishing, but they're ascertaining from a population that came to them for clinical testing and then comparing it to a population reference set, which isn't exactly the same. So to answer this question, the carriers study, which was led by Fergus Couch, and Kate Nathanson and I were part of this through Penn, was a population-based study of breast cancer susceptibility genes for risk assessment. Again, this has the nice advantage of having population-based cases and population-based controls from the same control. So this included prospective cohort studies with nested case control, and also just straight out case control studies as illustrated here. But the good news is we had 32,000 women with breast cancer and 32,000 unaffected controls. So this was a very large study to be able to answer the question that just in the general population, what's happening? And by the way, in the general population, how much cancer is quote unquote genetic? Because I'm sure you guys know that that number is highly variable depending on the population that you look at. So here what you can see is sort of the main table. I'll take you down to the first thing, which is that in all case patients, if you came up with you looked at the 12 genes, quote unquote, breast cancer predisposition genes, and you could argue about that term, but nonetheless, these 12 genes, which are sort of widely sort of accredited to be associated, 5% of an unselected breast cancer population had a mutation in one of those genes. And when you look at just BRCA 1 and 2, and we'll take PALB2 as closest thing to BRCA 3, we get to 2.6%. So this idea, and it might seem like a little difference, but it's really not. You'll hear that 5 to 10% of patients have like genetic susceptibility to breast cancer, but with the implication that that's all kind of BRCA 1 and 2. But it's really not. In terms of these high penetrance susceptibility genes, it's more in the 2 to 3% range. And a lot of the other stuff that you get is in things like CHEK2. As you can see, 1% of breast cancer patients have CHEK2 mutations, and 0.8% of ATM. So when you look at BRCA 1 and 2, though, you find that the odds ratios, are about what we see, what we'd expect. The odds ratio of breast cancer is about 7.7 for BRCA 1, maybe a little smaller for BRCA 2 in the general population than compared to high-risk clinics. But still, these numbers are chunky and substantial enough that it doesn't really change our mind about how we think about that. I'd also like to note that PALB2, the odds ratio here is 3.8. Again, that's a little lower than what's been seen in these family-based ascertained populations. So, the risk is a little lower, but still, again, no one would quibble about that risk. When you get to, and then one of the big questions that's always come up is, we have these criteria for genetic testing, but we should test everybody because otherwise we're missing people. And I would like to just sort of take this step back, and you can argue philosophically about that, and that's okay. But the real question that I just want to draw attention to is whether or not how many patients you miss for BRCA1 and 2 and PALB2, the genes that we have the most information about. And it turns out that risk stratification does matter. So if you don't have a first-degree relative with breast cancer, your chances of having BRCA1 or 2 or PALB2 mutation were under 2% compared to 5% if you did. And then if you go to patients who are ER positive, you can see this falls to 1.8%. But if you're ER negative, it's 6.2. And if you're triple negative, it's 8%. So these things really matter. And if you then start to add in things like age, because you can see that the likelihood of having a BRCA1 mutation strongly is variable by age, and also with BRCA2, then you can start to do a little math. And it turns out that if you're over 65 and you're not ER negative and you don't have a family history, you have a less than 1% chance of having one of these specifically high risk susceptibility genes. And it's notable too that in a different analysis from Mayo Clinic, 2 out of 126 women who were over 65 who didn't meet NCCN criteria had BRCA1 or 2 mutations. So we don't miss a lot of people when we don't test every breast cancer patient regarding BRCA1 and 2. But what we do miss is these, because these are the things that you actually, ATM and CHEK2 are the things that you generally pick up. So here we see again, ATM at 0.78, CHEK2 at 1% of all breast cancer patients. And CHEK2, the CHEK2 mutations are associated with breast cancer risk, and that 2.5 odds ratio is about what's been seen. But you can note that the ATM is down to 1.82, and that's often, that's less than having a first-degree relative with breast cancer. And so, how you're supposed to use that information becomes less clear, particularly when there's no family history. I wanted to note that 2 particular findings, CHEK2 I157T and CHEK2 S428F, which a lot of people argue are variants of unknown significance, and are reported out differently lab to lab. Some labs call these pathogenic variants, and some labs call these variants of unknown significance. And the reason why is because of this. It's all kind of long been thought that these are what we call low penetrance susceptibility genes, that they only raise the risk of breast cancer a little bit. So the question is that a pathogenic, is it really a VUS if we think it's related to risk, but it's not very high? What should we call these things? So another problem we have, right, is nomenclature. But here you can see that at least in the general population, these 2 are associated with very small increased risk of breast cancer, odds ratios of 1.3 and 1.26. But I'll tell you on an anecdotal basis, and I see Allison Warner-Lynn there, so I'm sure she can tell you, there's so many women with these who are determined to have bilateral mastectomies because they now have genetic risk. And it's almost impossible for me sometimes to walk this back, how this is not BRCA1, this is not BRCA2, this is something else. But I will tell you that I'm finding that I used to feel like I could communicate pretty well with patients, and now I feel like I'm having a much harder time explaining how one thing is not like the other. Because in a lot of patients' heads, not all obviously, but genetics is one thing and genetic susceptibility is one thing, and it's harder to kind of tease these things out. By the way, a lot of providers have the same problem, so it's not just a patient-related issue. So a lot of what we find, again, is CHEK2 and ATM. And then I just wanted to note that things like BARD and RAD51C and D are generally really kind of felt to be breast cancer susceptibility genes, but they don't really pop up in these analyses. If you do a separate analysis on ER negative, they look more significant, but ER negative cancers are the minority of cancers. So even how we explain this to patients, well, you're not at risk for breast cancer overall, but you do look to have an increase in triple negative breast cancer. RAD51C and do have ovarian cancer risk, so we have that piece as well. So you can see where communication-wise, we're struggling a little bit, I think, in the clinic to really have a consistent messaging across. So, but what does all of this mean for our therapy? And again, these lifetime risks of cancer related to some of these genes, like CHEK2 and ATM, depending on the devils in the details, may qualify you for breast MRI. But what a lot of people were interested in is, well, will they help with therapy? So this is a study we were involved with Nadine Tung at the VI, and this looked at olaparib, again, one of the PARP inhibitors, in breast cancer patients, metastatic breast cancer patients, with mutations in other genes. So here in the germline cohort, we had those with CHEK2, ATM, and PALB2 mutations. And in the somatic cohort, again, these were people who did not have germline mutations, but only had mutations in the tumor, looked at BRCA 1 and 2, ATM, PALB2. So obviously these are small numbers deliberately, but you can see here that in the germline cohort, the responses we see are all green. If you're not used to looking at these waterfall plots, below the line means the tumor shrinks. Below the dotted line means that it's a objective response. Above the line means it grows. Here's CHEK2 and ATM, and here's PALB2. It's not usually quite this obvious, by the way, when we look at these things. And so we can really see that there does not seem to be a signal here. And yes, the numbers are small, but still, this is actually kind of striking. When you look at whoops, and that was making the point. So when you look for, if you look at germline PALB2, that was in the green, although there were only 11 patients, the response rates, 82% had responses, meaning their disease shrank by predefined definition of response, and 2 had stable disease. And so that is really dramatic. When we look at the somatic cohort, these are tumors in mutations in the tumor only. BRCA 1 and 2 are in the blue, and you can see where they are over here. Whoops. And you can see that red is ATM. There's an assortment of other genes here. There aren't many PALB2 mutation carriers, but you can certainly see that somatic BRCA 1 and 2 mutation carriers seem to benefit. And again, here we can see that in those 16 people with somatic BRCA 1 and 2, there were 50% had partial responses, another 38% with stable disease, which is quite striking. So again, PALB2, 9 of 11 germline had objective responses. For somatic BRCA 1 and 2, 50. And here's ATM and CHEK2. None responded in the germline, none responded in the somatic. So again, when we talk about why we test for genes, we can come up with ATM and CHEK2, which have an increased risk of breast cancer, but not even close to the same level of risk as BRCA 1 and 2. And then people can argue, oh, well, we'll use that information for therapeutics, but so far we don't have any evidence that that is helpful to us. And this has also been seen in other studies. So this is a study of metastatic castrate-resistant prostate cancer, where the first cohort was BRCA1, BRCA2, and ATM, which was a weird thing to add on to it. And we can see a striking difference in terms of how these men do in terms of progression-free survival. But then when you look at the sub-analysis, you can see that the benefits were BRCA 1 and 2 and not ATM. So again, this is just making the same point. These are different genes. They have different implications. So this is all really important. And what we really know is that there has been this dramatic rise in the use of multi-gene panel testing. And this is this great study from Allison Kurian that if you haven't seen it, it was just published this week. I'm sorry, I'm checking my phone, but I'm also in clinic and people are in chemo. So, but this is just published like last week or the week before. And she looked over time at testing in the United States, what kind of testing was done, and then what we would find. And here you have BRCA 1 and 2. And if anything, you can kind of see this decline, which is just interesting because it just means proportionally we're seeing less because we're testing people basically at lower risk. And then we've got this this teal group in here, which by the way is mostly ATM and CHEK2. And then you see you can find some other what we consider, is considered actionable genes, but some of this is, SMAD4 and all these genes that have absolutely nothing to do with their cancer, their breast or ovarian cancer diagnosis. And then what mostly you get is this huge thing here, which is these are the variants of unknown significance, which dwarf our added value. And so I think, I've been talking a lot about, there's all this pressure to test more and more people. And I keep trying to fight back, but I'm losing the battle dramatically, is that if you're going to test more and more and more people, at least keep the gene list small so that we're not wreaking havoc. I have lost badly so far, but I'm going to keep trying. And I'm going to tell you why I think the VUSs are bad in a number of ways. And so again, one can argue about the teal group till the cows come home. We do MRIs for people with CHEK2 and ATM mutations. We don't have any specific evidence that in the absence of a significant family history, that's of a value. And I'm seeing so many mastectomies in CHEK2 mutation carriers. That I had another person today with an ATM mutation. And at some point, I can't try to talk people out of mastectomy anymore. It's become like, bang your head against the wall. And again, every situation is different. People with a strong family history, I'm not saying it's not the right move for everyone, but I'm sure you guys have had these conversations that the bilateral mastectomy rate is going up massively in this country. And the question is whether we're doing a good enough job communicating to patients really what the impact is on things like survival and outcome. And I'm just not sure we're doing, on my end, that I'm doing the right job in the communication. Okay, so let's talk about variants of unknown significance specifically. I think this group, well knows that variants of unknown significance should not be used for clinical management, and that we default to the personal and family history, and that the use of VUS has the potential to both overtreat and undertreat family members. And unfortunately, there are data from Allison and Allison's group and others in Sharon Plan that physicians do use VUSs in management. And this is sort of from one study that just showed that they would manage the VUS the same as a BRCA mutation carrier, 50% who had low volume, and it went down, but still it never got that low. So it is concerning that this information may be used this way. So I'm going to take you through a case study just because I think it just makes a lot of the points. Here, this is a patient of mine who had breast cancer at 45. Her sister had ovarian cancer at 37 and did survive that cancer. They had an unaffected sister at 43. This sounded like an ovarian cancer up here, but we couldn't get the details. Again, a cervical here. And initially, our proband gets tested, and she has this finding, a BRCA1, a variant of unknown significance. And this is how it was detailed. We all know that an additional problem is the changing nomenclature over time, and the fact that these things will be reported multiple different ways depending on the lab and when they're reported. And if you think it's all gotten better, I haven't checked recently, but up until recently, Foundation Medicine was still not using HGVS formatting. They were using, and if you don't use HGVS formatting, it takes, as we all know, forever to figure out exactly what we have in front of us. But I can promise you that this is in HGVS formatting. And so at the time, this woman had this, and a reminder that there are these, this is a group that's better familiar with this than I, and if Wendy's on the call, but there's, there's a well-established way to consider whether something's pathogenic or benign, and you get criteria for different things depending on this. But largely, to simplify it, because I'm a simple clinician, you have population data, you have computational and predictive data, you have functional data, which is awesome when you have it, but you usually don't. You have co-segregation data, and also the issue of whether or not you see it in cis or trans with another mutation. And you try to pull this data all together, these data all together. So this particular finding, and I actually did go in last night just to sort of update myself. This particular thing is called variant of unknown significance by Color, Ambry, Quest, Council, and LabCorp. So all of those continue to call it a variant of unknown significance. Of note, what happened in this family is that the ovarian cancer patient was already tested and positive, and this patient, the dad, was tested and negative. So look, it comes from mom's side. There's no ovarian. It's in the ovarian in the breast cancer patient. Obviously, it must be pathogenic. At least that's what we were pressured, because this woman wanted to be tested for this to make her management decisions. Okay, and so here is where you have to be super careful, because if we're wrong, if you test her and she's positive and she gets her ovaries out and we're wrong, that's bad. And meaning if it's not what's important to the family, and she's tested and you're negative and you don't take her ovaries out, that's bad too, if you're wrong. So again, you have to be very cautious when using limited co-segregation data. It's only helpful in aggregate across many families. And these are all the things that we do. Well, I'm not going to say that the routine clinic does this. We're lucky, like at Penn and Columbia, we have access and the ability to look at all these data sets. But out there in the community, I can assure you that none of this is happening, because it just can't. But this is, we look at NOMAD, it's in a well-covered region. We look at the population's frequencies, and it didn't exceed the maximum expected for a pathogenic variant, which just means that it could be pathogenic. Doesn't mean it is, just means like could be. You look at whether it's conserved, and it turns out it's well conserved. So you say, ooh, okay, well, it really could be pathogenic. You look at computational predictions, and actually they say probably damaging or deleterious. You have to be really careful with this, by the way. We don't love to use these. So now you're thinking, oh, well, all the data is going in one direction. But then it's not actually in the functional domain of BRCA1. And there are other variants like it in ClinVar that actually that have a different nucleotide that were felt to be benign. So it's confusing. But then in May of 2007, we were able to test the family again, and they had a large genomic rearrangement. And this is the cause of the cancer in the family, this large genomic rearrangement, not that variant of unknown significance. And so we frequently use this case, to really illustrate this point of it was really tempting to think that that variant of unknown significance was the cause, but it was not. And in fact, this information then goes back, because now we have an alternative cause for what happened in the family. And if it was in trans, it would reduce the VUS likelihood. Long story short, Myriad did update this to a favor polymorphism, so it's benign. But as we know, Myriad doesn't put their data into ClinVar, so it's not quite updated yet. But BRCA Exchange did look at this last year and did determine that it was benign. And so I did cheat a little bit, because I cut off the first top of ClinVar, which does say that the Enigma as a specialty interpretation group has called it, but all the commercial labs are still calling it a VUS. So you can see how we would have hurt this family by acting on it. And then yeah, I was just making that point. So again, this group knows this, but we don't want to, the exon 1 to 2 deletion is clearly deleterious, but the variant of unknown significance is not. And we still at Penn, and I'm sure everywhere, resist the temptation to equate a strong family history with the proof that the VUS is responsible for that family history. We talk to physicians about this a lot too. So the counter argument to this is you want to pay attention to VUSs, but you can't ignore them, and you have to have a way of keeping track of them. So this is a different case where this woman comes in and she has stage 4 breast cancer, and what's called the BRCA mutation on somatic sequencing. And her mother had unfortunately died of ovarian cancer and was BRCA negative by report. So this is our internal somatic sequencing. So this is a BRCA2 mutation. Again, it's a missense, and it was called out as deleterious by our lab. But when you went into ClinVar, what you found was 3 labs with pathogenic or likely pathogenic, and 2 labs with uncertain significance, including Invitae and myriad. So you had conflicting interpretations in ClinVar. And when we actually were able to get the mother's testing report, it turned out that it actually wasn't negative. It was a variant of unknown significance. And the family was told that the test was negative and don't worry about it. So, it's this touchy situation where we don't want to say, forget about it. We want to be somewhat reassuring, but at the same time, we can't act on it, right? And that does get tricky. But this case was painful because we now have a young woman with metastatic breast cancer, right? So, it's extremely difficult situation. So again, this is BRCA exchange, demonstrating pathogenicity. And I think you all know that there's all sorts of great things in BRCA exchange, which gives access to other databases, which you can see exactly what that's based on. Okay, so yeah, VUSs, you don't act on them and you don't ignore them. But we also have this problem with conflicting interpretations for patients and providers. And like anytime we get a VUS, we go into ClinVar or BRCA exchange and look. Anytime we get a missense or splice site, we go into ClinVar and BRCA exchange to look. And in the community, it's very unlikely that that's happening because you can understand why not. The other problem in the community, and also frankly at most academic centers, is that you need a way to document things in the medical record and communicate. And we've been working a lot on this at Penn, like how do you even find a test report, right? And we now have a precision medicine tab, and we're working with the labs to do HL7 and get the information directly into the medical record. Kate Nathanson has done an amazing job on that. But you also need a way to communicate changes in variants of unknown significance classification. And we do this every few years. We're re-engaging with our lawyers about, okay, a VUS was just reclassified, the patient's deceased. What do we do, right? And so we all are struggling with those same problems. And we also know that there are pending lawsuits related to the incorrect pending, and I'm sure finalized lawsuits related to incorrect interpretations of variants of unknown significance. As more and more testing is done in the community on more and more panels, there's going to be more and more of a problem, not less. Okay, so what's some good news? Most variants of unknown significance are classified downward. And this is a study we were involved in from a few years ago, showing that of those that were reclassified, 91% were reclassified downward, and only 9% were reclassified upward. But by the way, even that 9% is, that's a real number. It is extremely rare that things get reclassified from likely pathogenic to a VUS. That's really painful, and it does happen. And that was, if you guys read the Washington Post article maybe a year ago, that was what happened there. And again, that one would have always triggered us to look really closely because it was a likely pathogenic splice site. But again, how in the general community, they're going to just look at likely pathogenic. So that's the good news is that they mostly go down. The bad news is the volume, right? I mean, it's just striking what the volume is. If you get to hear 35, 40%, depending on the size of the panel. Obviously, the bigger the panel, the more VUSs. And the other thing that we know is a problem is that these are much more common in the minority population. So it's particularly problematic there. And it's not always kind of well recognized. And so, our first thing is if we see a VUS, and it's a VUS because it's never been seen before, and it's in a patient population. Okay, sorry, this is a clinical question. Okay. There, yeah, patient and chemo, yeah. There we go, it's taken care of. So so we have to watch after that, and if it's a first time that something's been seen in a patient population that hasn't had frequent testing, that's likely going to be nothing. But again, we have to be very careful about what we say. Okay, so how is information used? Well, Jada and I have been working on this study called PROMPT for several years, the Prospective Registry of Multiplex Testing, which is just a patients can come in to this registry on their own. This is genetic counselors have referred, that companies have referred, and we're basically trying to collect as much information on people with either VUSs or mutations in any genes as we can and prospectively follow them forward. We now have more than 8,800 people in this database, and the follow-up is actually ridiculous. Like more than 55% of patients have filled out at least one follow-up questionnaire, and many of them have filled out many. So we had a unique opportunity to see what was happening, and we were focused on removal of the ovaries for this particular analysis. How many people were removing their ovaries and why were they doing it? So the denominator here focused on people who didn't have BRCA1 or BRCA2 mutations. They didn't have mutations in genes where we would say we would recommend they have their ovaries out. And there are those, Lynch syndrome, RAD51C and D. So we took those out. We also took out everybody who had their ovaries out for other reasons. And they said it, like they had it out for endometriosis or they had a hysterectomy for one thing or another. These are only people who said they had their ovaries removed for prevention. They specifically coded it as preventative. 10% across the population did. In those people who had a VUS in what we would consider an ovarian cancer gene, so BRCA1 or BRCA2 mostly, over 15% had had their ovaries removed, okay? And again, for prevention in the setting of a VUS. In those who had a personal history of breast cancer but did not have one of these VUSs, it was 10%. And even people who had a personal history and no ovarian cancer VUS, it was about 7%. Now, if they didn't have a VUS and ovarian cancer gene, they're imprompt because they have a mutation in CHEK2 or a mutation in ATM. They all have some finding, okay? A CHEK2 or a VUS in something. But it gives you the idea that this is not uncommon. And these were all saying that they're doing it for preventative reasons. And then when you look a little further at this, you look first at those who had their oophorectomy and they have no first or second degree relative with ovarian cancer. That's more than 70% of people who are getting their ovaries out without a family history of ovarian cancer. And their oophorectomy is occurring at less than age 50. So the way to interpret this is that we are harming these people. They don't have a specific reason to have oophorectomy, either based on their family history. And even if you were to consider like an oophorectomy for other reasons, generally we don't do it at a premenopausal stage. The breast cancer patients are a little bit trickier because, again, some of them will have ER-positive disease, but even then, we can use Lupron shots now. We don't have to have surgical menopause induced on women. So these are just, these are surprising findings. And then we asked them why they did it. And so 43% overall, they said specifically that their provider recommended it. And in the VUSs, that was 54%. If you said that the provider recommended it or discussed it at least as an option, this goes up to 80% in the people with VUSs. 80%. And the only reason they're having their ovaries out is for their VUS. So you can see that these numbers are, again, we don't exactly know what's happening. We did not survey the providers. This is recollection from the patients. But women without a family history of ovarian cancer are having premenopausal oophorectomy, and in their mind, they are doing it because their providers have suggested it or specifically recommended it. So we are concerned about this, and it really does bear more data and study. So to be clear, genetic testing is highly impactful for women with breast cancer. But testing everyone, is not risk-free. I mean, even if you take away the costs, you have to consider, VUSs, and you have to think about this inappropriate management of VUSs. Allison Curran has other data that also look at this issue. So this isn't our study alone. Other people have seen the same thing. And I think a big point is that more isn't better, that this problem is going to be just magnified the bigger the panels we send. And by the way, we're still talking about panels. We're not talking about whole exome sequencing, and then you can get into a whole argument about, some people are like, well, you can do panels, just don't report back any of the VUSs. But as we showed, some VUSs are important. So telling people that their testing is negative and then coming back to them 5 years later and saying, oh, we told you it was negative, but you really had a VUS and now it's been up classified. I don't know. that seems even worse to me. Also, they now are not empowered to be checking in, right? They don't even know that there's something to check in on. So I'm not sure that I think that withholding the US information, at least in panel testing, is the way to go in a breast cancer patient. Again, we can talk about different strategies and population-based things. For these moderate penetrance genes, in the absence of a family history, I think that, more and more people are getting tested and finding this and having no family history. And what does an ATM mutation mean? It means less than a lot of people think it might. This disparity issue is a real thing, and I didn't get into that specifically today in the interest of time, but we don't test when we look at sort of the clinical data sets like from Ambry and things like that. And again, their data sets are amazing and very useful and have a ton of information, but it looked like Black women had a higher risk of having BRCA1 and 2 mutations at first, but it really was just that it took more to get them tested, if that makes any sense. So they were at higher risk coming in. So we have to be really keep an eye on those disparities, and particularly when we get to the US and how people are understanding them and acting on them. I think it's really important. So I deliberately left time for questions, but I did want to thank the many people at Penn and also throughout everywhere that I've worked with on this. So thank you for your attention, and I'd be happy to take questions at this point.
So thank you for a great talk, Susan. That was really something to hear. Let me ask people who have a question, want to make a comment, to use the raise hand function in your, if you're not familiar with it, click on participants at the bottom. And then under the list of participants on the right, you'll see raise hand as an option, and that will, in order in which you click, I'll have a list of people who want to speak, and I'll call on you and you can unmute at that point. Susan, let me start, if I can, with regard to the ever-growing number of genes on panels. How optimistic are you that that can be controlled? And do you have any thoughts as to how to do that?
Yeah, I think that, well, there's a few things. One is that I'd like to see some of the genes come off panels. So MRE11, why is it there anyway? I would, there's a whole argument about NBN. So I think that the idea that there are these kind of cancer specific panels that the companies are making, I think is a good thing. I think the problem is in part that there is a natural inclination in the United States to think more is better. And so, when people have a choice between sort of a 20 gene panel and a 139 gene panel, there's a little bit of like, why not do it all? And I think we have to continue to educate providers about why more isn't always better. I mean, I see Shana on, so I know she can speak from the standpoint of like, we did do whole exome sequencing a number of years ago on a research capacity, and we had 2 cardiovascular things that we had to hand back. And I got to tell you, those were probably the most brutal results disclosures I had done, because they didn't really have much going on in their family. And what did this mean? And these were pathogenic mutations. And I think that when we test for things that we weren't looking for in the first place, and then we get them back, it's really hard. So I would prefer to keep the gene list small, but given that everybody's talking about whole exome sequencing, I don't think I'm going to win that in any way. I think that everybody who advocates for whole exome sequencing should spend a lot of time in a genetics clinic giving results back for a while, and then think about it again, because I think that that's the people who are actually doing it on a daily basis. A lot of us are concerned, not everybody, but I just think that it's really hard to explain. I once had a patient who came in, and this was before the SNP panels were available. I forget where she got it done, but she had a SNP panel done somewhere, but she actually met criteria for genetic testing. So after she got genetic testing, she had a SNP panel showing she was at high risk. She actually had a variant of unknown significance in BRCA1. She had an MYH mutation, so that was recessive. And then she had like a CHEK2 VUS as well. And she nearly it was just so hard to explain. And I think that that's what we have to sort of factor into the equation. So sorry, that was a really long rambling answer, but I wish I had the answer.
Yeah, no, it was a great answer, and I really appreciate that. Do you think and let me just say, for folks who want to ask a question, if you can't make that raise hand function work, you can just use the chat to indicate that you'd like to ask a question, and I'll call on you.
I don't think there is a chat option, Paul, just that you know.
Well, then the chat option won't work. So use the raise hand option,
Yes.
or if you need to,
or shout it out. Yeah.
yeah, just unmute yourself and shout out.
Yeah, and I just wanted to quickly, this is Shayna, who Susan was referencing, and I just wanted to add that it becomes even more complicated because and those cases that Susan talked about, there's obvious harm done to those patients because they're so consumed with a cancer journey, and then you're throwing in something that is totally different. It wasn't even on their radar. It pulls the rug out from under them. It's something they're not even sure how to cope with. And in my role as someone who often deals with cardiac VUSs, but also has dealt with cancer VUSs and things, the challenge is not just from, we tend to think about it as uneducated providers, these non-genetics folks who don't know much about, VUSs. But a lot of the hardest battles that I fight trying to sort of back Susan on these smaller panels and, appropriate handling of VUSs is actually not from unknowledgeable providers. It's often from genetics professionals who just fundamentally feel like a VUS should be treated as a pathogenic mutation until it's proven otherwise out of an abundance of caution. And I think, it's something I'm interested in looking into, but this is more of a comment than a question, but it really is more than just educating non-genetics professionals. It's really actually also educating genetics professionals on the downstream consequences of sort of what happens. And so I think the research like Susan's doing with how many people are getting oophorectomies when there's no indication for such, a lot more of that research needs to happen because there's such limited research out there on those types of issues.
Great, thank you. So we have Rochelle Manukian. Do you want to unmute yourself? Go ahead.
Yes. Hi, this is Rachel. Hi, Dr. Domchek. I'm a genetic counselor at City of Hope. A great presentation. So I just, I totally hear what you're saying about, some say more genes, larger panels. It's essentially population-based and research at that point when you're doing these huge panels. And I communicate these VUS results, and I totally see that struggle. And then I have the balance of, well, by testing more genes and testing more people, then we're reclassifying VUSs and able to do that with more information. So, what are your thoughts on that and finding that balance? And is it just more research, or, what do we need to do?
Yeah, it's a great point. I mean, one thing that you're bringing up is, the research versus clinical. Like, are people sort of engaging in research by their clinical testing, right? And in some ways they are. That doesn't mean that's, for some people that's okay. But I don't think, part of the problem is time. What happens is, for most people, still their results are negative and they don't have a VUS. And then they're like, great, I got tested for all this stuff and I'm clear. And I think one of the problems is that a lot of the research that's done, when they look across the population, we don't see psychological harm because we actually are not looking at the people that were harmed, and overall people are okay. So I do think that doing more research, and also what should the informed consent process be? I mean, I think we've all gotten away from the fact that, like, in the old days, it was an hour, and did people have to understand DNA and all this kind of stuff. And now it's a lot more about how will this information be used and what will it mean to you, right? And that's why, when someone has, it can be really context specific. So when someone has advanced cancer and they're really just looking for maybe a therapeutic target, they are maybe much more willing to go big. And when, you have an unaffected 25-year-old, then, you're really like, what am I doing here? Do I even need to know about this gene right now? And some of the argument that you hear back on that is like, well, you only get one chance to test somebody. And I hope we can get away from that. I hope we can, because I definitely have done things like, okay, you're 30 right now. What I need to know about is this, and we can do all this, but they're like, listen, just the important stuff right now. I got too much going on. And but how do we do that efficiently? How do we get informed consent and education efficiently? Because we can't go through every possibility. That wasn't really much of an answer either, but I see Jada's hand up, so I'm hoping she answers that conundrum.
Jada, do you want to unmute yourself and go ahead?
Sure. I don't know that I have exactly an answer, but I just wanted to comment. I think your point about the psychological implications and what we're seeing there is so important, because it's somewhat, I think, concerning and inconsistent with some of the clinical experience that we all see. That the data thus far aren't necessarily showing dramatic negative psychological impacts in response to uncertain results or VUS results in this space. And there have been a couple of nice meta-analyses, or at least systematic reviews, that came out in the last year to this effect. But I think that what is sort of the really important nuance piece that our current studies and our assessments aren't capturing is what's really happening in that communication exchange between the patient and the provider, right? So the report may say a VUS, but as you've alluded to, Susan, there's such an important distinction between how does the provider contextualize that result to the patient. What are they really telling them? To what extent are they considering the family history? And what are in turn the clinical management recommendations that are given, as well as what the patient walks away understanding, that I think is such an important sort of effect modifier or moderator of these interactions that we're just not adequately capturing to date. So I think that, trying to disentangle what's really happening in the scope of potential patient harms really has to be getting at that communication. And that communication may be the communication between multiple providers, not just what you hear from your genetic counselor, if you are lucky enough to speak with one, but also what your oncologist is telling you, or your primary care provider, and how you're weaving together those multiple, inputs as you as a patient try to make sense of this.
Allison Werner-Lynn.
I wanted to follow up on that. I think, Jada, what you're saying is right on. And part of what we talk about in the patient side is how risk adverse, how anxious, how concerned, how worried patients are, and how that moves them towards decisions, perhaps preemptively, perhaps in the context when oophorectomy, as you presented, Susan, isn't really recommended, but they're saying it's recommended. So it may be that we also have to be looking at the provider risk aversion and risk aversion across a number of dimensions. How comfortable are they giving VUS results back? How comfortable are providers explaining what that means? And it's hard when it's uphill, as you were saying. So something happens in the middle of those two experiences, or those multiple experiences of risk aversion or risk tolerance, that lead to those, I think, preemptive actions.
Yeah. Well, it's interesting. This reminds me of my mother-in-law is from Kentucky, and I didn't change my name, and I work outside the home, and sometimes that's not gone so well. But about 10 years ago, she was diagnosed with a tiny little breast cancer. And I was talking to her on the phone, and I was like, you're 78. I don't think you really need that Oncotype for the 6mm cancer. And I really don't think you need the breast MRI. And these are things that, could get you into trouble one way or the other. And her response was, well, I'm glad my doctor is being thorough. And so the other thing to realize is that these women who in our prompt survey said they had an oophorectomy are not necessarily psychologically harmed by that decision. They might have answered on those surveys that they were perfectly happy because their doctor was being thorough and aggressive, and that they wanted them to be so. So I actually think it's interesting. Psychological distress is not necessarily always the measure, right? So, which is kind of strange, but especially in the United States, where more is almost always construed as better. I think that's another thing that we have to be cautious about. My patients who are getting bilateral mastectomies for CHEK2 mutations, they are very happy with their decisions. So then why do I have a problem with it? Why should I be upset about it? Right? And that is a question, right? Maybe I shouldn't be concerned about this if the patients are happy with their decisions, right? That's a whole another metaphysical topic, probably.
So we're going to have to bring this to a close. Fascinating presentation, great discussion. Thank you, everybody, for joining us. Keep in mind, our next seminar is on March 15th, and Steve Jaffe from Penn, ethicist, oncologist, will be with us then, and will get you information within the next week about his topic. So thanks, everybody. Susan, thank you so much.
Thank you. Take care.
Terrific.